Hello everyone, welcome to Pathomed. Today, let us study about osteosarcoma. Osteosarcoma is the most common primary malignant tumor of the bone. It has various histological variants and they can be classified into the central variety, that is that which is present inside the that which arises within the medullary cavity, and peripheral or the surface, that the tumor arises on the surface of bone. Again, the central osteosarcoma can be further classified into the conventional variety, the conventional intramedullary osteosarcoma, low-grade osteosarcoma, telangiectatic osteosarcoma, and small cell osteosarcoma. These four variants come under the central osteosarcoma. Coming to the peripheral osteosarcomas, peripheral include parosteal, paraosteal, periosteal, and high-grade osteosarcomas, high-grade surface osteosarcomas. Firstly, let us study about the central osteosarcomas. I repeat once again, under the central osteosarcomas, we have the conventional intramedullary osteosarcoma. Based on the type of matrix which is predominant, it is classified into osteoblastic. That means the matrix predominant matrix is formed by osteoblast. Chondroblastic, that means predominant matrix is formed by cartilage. Fibroblastic, that means the predominant matrix is the fibrous tissue or the fibroblast. Again, the second variant is low-grade telangiectatic small cell. Firstly, let us study about the central osteosarcomas. Under the central, first let us see the conventional variety, conventional intramedullary osteosarcoma. This is the most common variant that you encounter. It accounts for almost 75 to 85% of all the osteosarcomas. And the most common site being that means it arises from the metaphysis. It arises from within the metaphysis of long bones. For example, this is a long bone, this is a metaphyseal plate. The tumor arises from the metaphysis and it does not cross the epiphysis. And the most common age group affected are 10 to 20 years. Younger people are affected by conventional variety and the males are affected more than the females. Let us see the locations where they get affected. Around the knees is 60%. Around the knees means lower end of femur and the upper end of tibia. Lower end of femur, upper end of tibia. This is the most common site affected or affected by the osteosarcoma, almost 60%. Second most common is the hip bones. Hip bones, this almost 15%. Proximal humerus 10%, third most common site, proximal humerus, the head, proximal humerus almost 10%, and the mandible least common. Mandible is the least common, 8%. These are the sites affected by osteosarcoma. What are the precursors for this conventional variety of osteosarcoma? These are most commonly associated with various syndromes like familial retinoblastoma syndrome, Ollier disease, Maffucci syndrome, Rothmund-Thomson syndrome, and lastly Lee-Fromenni syndrome, in which there is a germline mutation of TP53 gene. I repeat once again that there are certain precursors that lead to the development of conventional osteosarcomas. These are associated with all the syndromes, all the named syndromes, like firstly familial retinoblastoma syndrome, second is Ollier disease, third is Maffucci syndrome, fourthly Rothmund-Thomson syndrome, fifthly Lee-Fromenni syndrome, in which there is a germline mutation of TP53 gene. Coming to the molecular pathogenesis, that means how does this cancer develop? Like regularly, as such with any other cancer, any other malignancy, there are certain genes involved. For example, mutation of certain genes lead to uncontrolled cell growth. Those genes are the RB tumor suppressor gene. RB gene is a tumor suppressor gene. It is present on chromosome 13, P14. When this tumor suppressor gene is mutated, the cell cycle gets unchecked. For example, here this is RB protein. If when it is phosphorylated, the cell cycle moves from G1 to S phase. And unless and until it gets phosphorylated, the cell cycle does not move forward. If there's a mutation of this RB, it does not check the cell cycle. So the cell cycle gets unchecked. Cells proliferate without any control. Mutation of this RB. And also mutation of P16, P14, that is also called ARF, cyclins D, CDK4, cyclin D. All these are mutated. P53 gene, which is again a tumor suppressor gene, CDK4, P16, cyclin D1. All these are mutated. The net effect will be increased in cell cycle proliferation. And there is increased baseline activity of all the growth factors like fibroblast growth factor 3, platelet-derived growth factor beta, and HST1. HST1 most commonly associated with osteosarcoma. The net effect of all this is increased growth factor. Increase in growth factors means increased signaling, which ultimately causes increased cell cycle. And there's inactivation of INK4A, also for CDKN2A gene. This CDKN2A gene, it encodes for P16 and P14, which are again involved in cell cycle. When P16, P14 are lost, the checkpoint on the cell cycle is lost, and hence the cell proliferates uncontrollably. The net effect of all these are the mutation of all the tumor suppressor genes. Mutation of tumor suppressor genes are RB gene, P53, and also certain cell cycle checkpoints like CDK4, P16, cyclin D1, INK4A, that is CDKN2A gene also, which codes for P16 and P14. And this increased activity of growth factors, simultaneously there should be increased activity of growth factors like fibroblast FGF3, PDGF, HST. All this, the net result will be increase in cell cycle and cell proliferation, which is uncontrollably increased, ultimately leads to cancer, which is osteosarcoma here. Coming to the clinical features, firstly, it starts off with a mild intermittent bone pain. When the tumor, as for example, the tumor rising from within this cavity. First, initially, it is mild pain, intermittent pain. As the tumor grows in size, it grows and grows, it breaks through the cortex and invades the adjacent tissue, and it breaks through the cortex, it lifts the periosteum. It ultimately leads to pathological fracture. The bone becomes fragile and it is very susceptible to fractures. That is called pathological fractures. Bones become fragile because of this overgrowth of the tumor. And in cases of metastasis to lungs, where the lungs is the most common organ that receives the metastasis, their patient presents with respiratory symptoms. The lab investigations, it shows increase in serum alkaline phosphatase. ALP is increased, alkaline phosphatase is increased. These are regarding clinical features. The radiology shows you the classical Codman's triangle. Why Codman's triangle? Because this is the tumor, this is the lytic tumor, this bone destruction here. As the tumor grows and grows and it lifts the periosteum, there is a periosteum covering the bone, and this periosteum is lifted off because of the growing tumor. It casts a shadow in a triangle form. This shadow this triangular shadow, it is called Codman's triangle. Codman's triangle is the shadow formed by the lifted off periosteum because of the growing tumor. Other finding will be, for example, at the ends of long bones, the tumor grows here and it gives out like a rays of a sun. It gives out spikes like a rays of sun. This is called sunburst appearance. These two are the characteristic findings that you see in conventional osteosarcoma. Coming to the gross findings, this osteosarcoma, it is non-homogeneous. It has different appearances, but these are firm and gray white in color, mostly gray white in color, and they are non-homogeneous. For example, here it is gray white. It is central in location. It is highly cellular, and also here and there are areas of hemorrhage here, necrosis is there. Here also The tumor is non-homogeneous. Certain areas are cellular, certain areas are hemorrhagic, certain areas are necrosed. Here also, there are areas of hemorrhage and necrosis. So it is a non-homogeneous tumor. And mostly it is affecting, as the tumor arises from metaphysis, the ends of long bones are affected. But the epiphysis remains unaffected. Here the epiphysis remains unaffected. Coming to the light microscopic findings, the cells, all malignancies, they show pleomorphism. So here also the cells show pleomorphic features. The cells are polyhedral or spindle shaped. The nucleus is hyperchromatic. There is increase in NC ratio, nucleus cytoplasmic ratio is increased, hyperchromatic nuclei, and numerous mitotic figures. Mitotic figures means the cells, inside the cells, the nucleus is shown in a dividing phase, active dividing phase. So the presence of mitotic figures, it indicates the aggressiveness of the tumor. And there's a new bone formation. This formation of new bone, it appears like a fine lace-like pattern. This is important and very diagnostic of osteosarcoma, fine lace-like. Lace is nothing but a delicate fabric work. Delicate, it is a mesh-like mesh work of fabric that is stitched along the clothes to give it to beautify the fabric. Along the dupattas, this is a lace dupatta. The ends have the lace. It beautifies the garments. This is a delicate mesh-like framework. It's an artwork that beautifies, enhances the beauty. So it is the newborn formation occurs in this pattern, lace-like pattern, and this is very diagnostic of osteosarcoma. This is the microscopic image of an osteosarcoma. Here, the cells, the purple cells, the purple are the nuclei of the osteoblast. In between, this light pink, this pink, diffusely, delicately spread meshwork-like thing is nothing but the osteoid bone formation. This is the osteoid bone formation. Osteoid bone formation. This delicate pink framework this delicate pink framework is the osteoid bone formation. This on low power it gives an appearance of a delicate framework, delicate lace. This is a delicate fabric lace like it appears like a delicate framework. Hence, it is given the name fine lace like fine lace like pattern. Fine lace like pattern which is characteristic of an osteosarcoma lace. And since the matrix, most of the matrix is composed of this osteoblast, hence the name is given as osteoblastic osteosarcoma. Also, as we have discussed in the first slide during the classification, depending on the predominant matrix, the name is changed. Here, the predominant matrix is the cartilage. This is the cartilage. Predominant matrix is the cartilage. This light pink is the unmineralized osteoid. This dark pink is the mineralized osteoid. Since the matrix is cartilage, it is given the name chondroblastic osteosarcoma. This is the predominant matrix shows you certain spindle-shaped cells. These are spindle-shaped cells. Here, this is spindle-shaped cells, spindle-shaped. These are the fibroblasts, the spindle, long, elongated elongated tapered ends, spindle-shaped nuclei can be appreciated. These are nothing but fibroblasts. This pink, light pink color is the osteoid. This light pink color is the osteoid. Osteoid, like a fine lace-like pattern. Since most of the matrix is comprised of fibroblasts, it is given the name fibroblastic osteosarcoma. Let us see the modes of spread. They invade locally, they are locally aggressive, and also they metastasize through blood to the lungs. Lungs is the most common organ involved. It spreads through the blood. First, let us see the local spread. This is soft tissue invasion. First, the tumor arises from the metaphysis and it extends and fills the medullary cavity. Inside the medullary cavity, normally bone marrow is present, but the bone marrow, for example, this is the bone. This is the marrow. As a tumor rises metaphysis, it grows, it completely fills up this medullary cavity, replaces the normal bone marrow. It replaces the normal bone marrow. It is given a name called permeative growth. It is called permeative growth. If at all it breaks through this cortex, and it can enter into the adjacent soft tissues as well. Joint cavity involvement is very rare. Usually these joints are spared because they do not cross this epiphyseal line. Usually they are spared, but they can also affect the joint capsule. They can also affect the joint capsule if at all they spread along the ligaments, tendons and ligaments. If they spread along the tendons and ligaments, they involve the joint cavity as well. This is an unusual situation. This image shows you permeative growth. That means this is a biopsy taken from the bone marrow. The entire bone marrow it is replaced by this bony trabeculae and the tumor cells. This is called a permeative growth. Permeative growth. Hematogenous spread, that means this osteosarcoma, it spreads through blood. First common organ involved is the lungs. Lungs first involved. Later, liver, brain, and the bones are involved. Liver, bones, brain are involved in the later stages. Let us have a recap of this conventional variety. Conventional variety, most common 75 to 85%. Site is metaphysis, 10 to 20 years of age group. Males more commonly affected. Organs locations are around the knees, hips, proximal humerus, mandible. It is associated with most of the syndromes. There is mutation of all the tumor suppressor genes and increased activity of the growth factors. See, there is a mutation. There should be mutation of suppressing gene mutation and increase in activity of all the growth factors. The net effect will be increased cell cycle. Clinical features will be initially there is mild intermittent pain as the tumor grows and lifts off the periosteum, the bone becomes fragile, there will be pathological fractures. If at all lungs are involved, respiratory symptoms. Lab investigations, there is increased ALP. Radiology, most famously Codman's triangle and sunburst appearance. Gross image, it is non-homogeneous. Microscopy, the lace-like pattern. Remember the fabric lace-like pattern. This is a lace-like pattern here, the pink material. The matrix is predominantly osteoblast, it is osteoblastic osteosarcoma. If cartilage, it is chondroblastic osteosarcoma. If fibroblasts are forming the most of the matrix, it is fibroblastic osteosarcoma. Modes of spread, locally it can spread or metastasize via blood to the lungs. Local spread, when it fills up the medullary cavity and replaces the bone marrow, it is called permeative growth, and it can also break through the cortex into the adjacent soft tissue. Joint involvement is very rare. It mostly spares the joint because it does not cross the epiphysis. But unusual situations, it can involve joint cavity if at all the tumor spreads through tendons and ligaments. This is a permeative growth. Tumor completely filling up the medullary cavity. The spread is via blood. Firstly, lungs are involved. First, lungs. Later, liver, bones, and the brain are involved. Now, the second variant is the low-grade intramedullary osteosarcoma. It's a rare variant. Age is third decade to fourth decade. Equal. Males and females are equally affected. Sites being the femur and the tibia. There's history of pain without swelling over many years. It goes over many years. Radiology is not very characteristic because it has a poor demarcation. In radiology finding, there's a poor demarcation between where is the tumor, where is the adjacent normal tissue. There's no demarcation. This is the gross image. The tumor it is gray and gritty. That means on cutting the bone, you find gritty sensation. And it shows it can have fibrous and fleshy appearance. This is the gross image. It can have either fibrous or fleshy here, fleshy appearance here and there, fibrous appearance are there. And there's a poor demarcation. We cannot demarcate where is the tumor, where is the normal bone, where is the normal cortex, unable to identify. Poor demarcation. And microscopically, this characteristic thick bony trabeculae. This is the trabeculae. This is the bony trabeculae. It is thickened bony trabeculae, and this is the stroma containing spindle cells. And the spindle cells are very low in number. Hypocellular spindle cells, thick bony trabeculae, characteristic of low-grade variant of osteosarcoma. Done. Coming to the third variant, telangiectatic, that means something to do with blood hemorrhage. So, it is the most aggressive tumor and it is highly sensitive to chemotherapy and radiotherapy. It responds well to chemo and radiotherapy. Most common age group is second decade. Sites are the distal femur, the distal femur, sorry, the distal femur, proximal tibia, and humerus, proximal humerus. Radiologically, it resembles an aneurysmal bone cyst. This is this is a radiology finding. It shows you like aneurysmal bone cyst, multiloculated, multicystic appearance, like a soap bubble appearance. This is the proximal end of the humerus. It appears it is similar, the radiology finding is similar to an aneurysmal bone cyst. Microscopically as well, it is similar to aneurysmal bone cyst. These are the cavities. These are the cavities. It is filled up with this RBCs, these dots, tiny dots inside are the RBCs. So cyst cavity filled with blood, and this is stroma filled up with this neoplastic cells, neoplastic osteoblasts. This is a gross image. See the tumor here. There's a bleeding, areas of hemorrhage, large area of hemorrhage, characteristic of telangiectatic osteosarcoma. How do you, it is very similar to an aneurysmal bone cyst, but you can distinguish it from an aneurysmal bone cyst because aneurysmal bone cyst, it is associated with USP6 gene mutation, which is not found in this telangiectatic osteosarcoma. Telangiectatic osteosarcoma does not have this USP6 gene mutation. Coming to the last variant under the central osteosarcomas, that is the small cell variant. Small cell variant, it resembles the Ewing's sarcoma because both Ewing's sarcoma and the small cell variant, the tumor is composed of small round blue cells. This is the small round blue cells, small round nuclei stained. The purple is a nuclei stained small round blue cells. These are small round blue cells. Small round blue cells. Here, this pink material is like a meshwork. This is the fine lace-like osteoid matrix production. Osteoid matrix production. This fine lace-like osteoid matrix production. And both Ewing's sarcoma as well as small cell osteosarcoma, they show CD99 positivity. CD99 positive as an IHC marker. Then what is the difference? The only difference is the osteoid sarcoma. The osteosarcoma shows you this lace-like pattern, osteoid matrix production. This osteoid fine lace-like meshwork, osteoid matrix production is the only distinguishing factor between a small cell osteosarcoma and Ewing's sarcoma. Ewing's sarcoma do not show you this osteoid formation. Small cell osteosarcoma shows you. We have completed the central osteosarcomas. Let us have a quick recap. Conventional osteosarcomas, we have revised it. Conventional variety. Low-grade osteosarcomas. This is a rare variant without any swelling. These are poorly demarcated tumors. Even grossly, they are poorly demarcated. It can give you a fleshy appearance or a fibrous appearance. Microscopic is thick trabeculae and hypocellular spindle cell stroma. Telangiectatic means something to do with blood vessels or bleeding, so most aggressive and sensitive to chemo and radiotherapy. It resembles an aneurysmal bone cyst. Radiologically and microscopically, it gives you this multiloculated soap bubble appearance. And also in the microscopy also there are numerous cysts filled with blood, and the intervening stroma contains the neoplastic cells. Gross image also shows you large areas of hemorrhage. Small cell osteosarcoma resembles the Ewing sarcoma because it contains small round blue cells, and also CD99 is positive for both small cell and Ewing sarcoma. The only distinguishing point is this osteoid bone formation. Osteoid bone formation seen only in osteosarcoma, not in Ewing's. Till now, we have completed the central osteosarcomas. Let us move ahead to the peripheral osteosarcomas. Peripheral osteosarcomas. Under peripheral, we have paraosteal, periosteal, and high-grade osteosarcomas. Firstly, paraosteal. Paraosteal means, first let me draw a diagram. This is the bone, cortex of this white. This is up to the cortex of the bone. This is the cortex of the bone. This is the periosteum lining the cortex of the bone. For example, if the tumor it arises on the surface of the periosteum and it wraps around the bone, it arising on the surface of the periosteum. This is paraosteal. This is called paraosteal osteosarcoma. Paraosteal osteosarcoma most commonly shows you MDM2 amplification. MDM2 amplification. And also microscopically, it shows you very thick bony trabeculae. Very thick bony trabeculae and hypocellular, again, hypocellular fibroblastic stroma. MDM2 amplification is seen only in paraosteal osteosarcomas. Whereas now coming to the periosteal osteosarcomas, in periosteal, if the tumor arises between the cortex and the periosteum, this tumor is called periosteal osteosarcoma. Periosteal osteosarcoma. Microscopically, it shows you cartilage differentiation. Mostly cartilage differentiation is seen. Almost similar to the chondroblastic variety, but it arises from the surface, not inside the medullary cavity. And grossly, hardly you can find, because periosteum is very thin like a paper, you can hardly find out. Here, this periosteum is intact here. It arises on the surface of periosteum. Whereas periosteal, it arises from within, between the periosteum and the cortex. Between them, this tumor arises. Here, the cortex is intact, periosteum is intact, the tumor arises outside. There's no periosteum here overlying it. This is the difference. Because in periosteum, it arises between the periosteum and the cortex, it is lined by periosteum outside. The overlined it is overlaid by this periosteum. It shows you cartilage differentiation, periosteal tumors. Also MDM2, most importantly, MDM2 amplification seen only in paraosteal osteosarcomas. Coming to the last variant, high-grade surface osteosarcoma. It is very similar to the high-grade conventional osteosarcoma, but the difference is it arises on the surface of bone. It arises on the surface, not within the cavity. And also, before giving the report as an high-grade osteosarcoma, you have to rule out paraosteal osteosarcoma. So, how do you rule out paraosteal osteosarcoma? By diagnostic testing of MDM2 amplification. MDM2 amplification test, if it is negative, then you can proceed forward as high-grade osteosarcoma. We have completed the peripheral osteosarcoma also. That includes parosteal, that means it arises outside the surface of periosteum and it wraps around the bone, so it is not lined by the periosteum. It shows MDM2 amplification. Microscopically thick bony trabeculae, hypocellular spindle-shaped stroma. Periosteum, it arises between the cortex and the periosteum, so it is overlined by the tumor is lined outside by the periosteum. So microscopically it shows you cartilage differentiation. High-grade osteosarcoma, it is similar to the high-grade variety of the conventional osteosarcoma, but it arises on the surface of the bone. You have to rule out the parosteal variety by doing this MDM2 amplification test. This MDM2 amplification is positive only in parosteal. It is negative in the high-grade variant. High-grade variant do not show you the amplification. That's all. We have completed the central osteosarcomas and the peripheral osteosarcomas. Central osteosarcomas we have done with conventional variety. Low-grade osteosarcomas, telangiectatic, small cell. Telangiectatic resembles aneurysmal bone cyst, whereas small cell it resembles Ewing sarcoma. Parosteal showing you MDM2 amplification. Periosteal shows you cartilage differentiation. High-grade osteosarcomas. That's all we have done with the osteosarcomas and its variants. Thank you everyone. Please like, share and subscribe. Have a nice day.